This is Miss Layla. She's a 3-year-old female spayed pit mix that presented to us 4 days following a bonfire gas can incident. She was managed during these 4 days on an outpatient basis with the primary veterinarian with bandage changes. This is our first surgical debridement. You can see post-burn injury. I'll be using that PBI throughout to let you know the timeline. Here on her lateral thigh, you can see that she's missing quite a bit of tissue. These areas are still declaring themselves. And then this is the groin area or inguinal region here where the tissue doesn't look very good and is still declaring. Here we have the perianal region. The forceps are near the perivulvar area and kind of undergoing the first surgical debridement here. On her dorsum, you can see this darker delineation is showing what does feel firm on palpation, likely an eschar that's going to further declare over time. So the first question is, how would you manage this patient? My first gut reaction was absolutely to refer her to a different surgeon. But after that panic, we discussed managing her kind of on a co-management basis with our critical care service. On presentation, she was actually fairly stable. However, she did need multiple blood transfusions. She had a long line placed and an esophageal feeding tube placed right away. And then specific to the wounds, we took sort of a watch, wait, and see approach with conservative debridement before we came up with a long-term plan. Long-term for her, our initial thoughts amongst the surgeons at Iowa State was that she would probably require a left hind limb amputation and possibly a tail amputation based on missing so much skin. Then we could use the distal skin from those two areas as a graft. We also wondered if her caudal superficial epigastric flaps would be available, given that there were burns within her inguinal region. We weren't sure about that. And certainly there's not enough free grafting material left to free graft everything, but maybe with some staged procedures over time, we could do that. Here you can see day 7 post-burn injury, lots of edema and swelling within the tissues. There are some islands around her stifle that are looking really good. And then her vulva here is still very swollen with her urinary catheter in place. Along her dorsum, that area has further declared itself. And then within the groin inguinal region, you can definitely see along here that lots of tissue still needs further debridement. On her dorsum, again, you can see that delineation extending cranially at this point. With her management, there were some things that were very specific that were a challenge, one of which being the surface area estimated to be about 60% burn. The bandage was quite extensive. And while she was recumbent, it was a lot easier, but once she was more mobile and happier, that became a challenge. And then having a fecal and urinary catheter system in place for a long time was also a problem. And at the beginning, we definitely struggled with keeping her comfortable pain-wise as well. We wanted a more general debridement of this large area, and so we ordered medical maggots to try. It was hard to keep them in place, especially on the dorsum with the stockings. However, they did migrate towards the perianal region, which ultimately I think was a really good thing because that was the dirtiest area, and I think it really helped us. This is day 14 post-burn injury, where we can see some really nice granulation tissue coming that's light pink. There are still some areas that we need to surgically debride, and specifically along the dorsum, you can see that this area is still declaring itself more cranially. But within the inguinal region, we have just a superficial area, so we're hopeful those vessels are intact, which ultimately now the question is, where are we going to get all the skin from to repair her defects that she has? And so we confirmed with ultrasound that the caudal superficial epigastrics could be used. Those vessels were intact, even though the superficial skin was not. And then she doesn't have much of a flank fold. You can see on the left side in these images, she doesn't really have flank fold left. And I don't have a great picture of the right, but it was very limited on the right at this point as well. And then we discussed free grafting from different areas for her. So here we can see that she's got these nice islands, some of which actually have hair in them along her stifle. So at this point, we've decided, we're not going to amputate this leg. There's a lot more potential there. And same thing with the tail, we're going to hold off because at the end of the day, we still have to be able to close over those areas of surgery. And so that's still kind of on the docket. Looking at her dorsum, it's fully debrided at this time, and we're starting to see some epithelial tissue around her anus and her perivulvar folds. And consulting with Dr. Stanley about this case, she recommended to go ahead with preconditioning the right caudal superficial epigastric flap. And the reason she thought we should precondition is to maximize not losing this flap, wanting to use as much as we possibly could. So ultimately, that's what we did on this day. You can see us preconditioning. You can start to see some epithelialization along the dorsum, some really great granulation tissue. And then about 9 days later, we chose to rotate that flap. You can see that we islandized it here to get the most rotation out of it. Also, we were missing some of the skin in that area. So the vessel was definitely intact, but islandized that to maximize our rotation. As we're closing down to the granulation bed, you can start to see venous congestion and edema here already. And then we wanted to prioritize this perianal region so we can get this fecal catheter and the urinary catheter out as soon as possible. So the goal was to use the other caudal superficial epigastric in a staged fashion, either along her dorsum somehow or the other side. But we did split thickness grafting at this time to try to see if some of that would work. And her right thorax was the donor site, which we let heal, or we closed primarily, excuse me. And then the complications that we had with this flap, of course, happened. So on the bottom left, you can see day 4, 6, and 10 after rotating the flap. I estimated that we lost about 15% of the distal flap to necrosis. And then you can see within this perianal region, we did start to have some spots of epithelium that did take. You can certainly see the venous congestion within that led to a little bit of tension and dehiscence right along that anal tissue right there. And we did have some fecal leakage under that flap as well, which I think all contributed also. Several days later, we were in touch with the Kerecis company from Dr. Stanley's recommendation from their Michigan State case they had used it on, and they donated cod skin for us. So this is her before we applied the cod skin, and you can see the perianal region is completely healed, almost just some small areas. That graft looks really good. The venous congestion is gone. She's starting to epithelialize. You can see the rotation site's fully healed, and then that inner thigh on the right still needs a little bit. So we meshed the cod and applied it. It took 3 boarded surgeons and 1 or 2 residents close to 6 hours to complete all of this. And then just like in people, they recommend that we vac over the top, which we applied the vac, and we did use some ostomy paste along her tail and perianal region to get a good seal. And then I wanted to show what it looks like after removing the vac 5 days later. You can see that the cod skin has incorporated within the granulation bed, which is what the rep said it should do for best progress and expediting the epithelialization process. So looks really good. She's quite bored in her pajamas or bodysuit with us at this point. And then a few days later, everything is looking good, but we have one company kind of led to another, and they introduced us to the RECELL product, which is a autogenous spray-on skin material that they use on the human side after using the cod skin. So here you can see that I'm scraping the skin cells, and then we're going to put the skin cells into the syringe and spray it onto the wound bed here. We used her left thorax as the donor site at this point, and then allowed that to heal by second intention. So this is what the system looks like. It is a specific buffer system. You do your split thickness, you put that in there, and then here I'm at the point that I've gone through all of that. The rep scrubbed in to help us with this product as well, and certainly we don't know how it works in dogs. After applying the spray-on skin, you apply this sheet, which is a clear plastic sheet, and then bandage routinely. Here's our donor site that we also used the spray-on skin for. And after taking that off, they recommend about a week. We thought we were getting some secondary infection at that point, so we removed that system at about 5 days, and this is what we had. So we had done some split thickness grafting as well, and you can see that area is looking really nice. She still has this area on the dorsum, but that entire left leg is completely healed with only a tiny few millimeter strip on the inner aspect of that thigh. This is day 81, so she's been hospitalized with us for 77 days at this point. The owners live 3.5 hours away, so she hospitalized with us longer than most patients would have because they couldn't come in and out for bandage changes. Here's a screenshot at 120 days when we saw her for one of her bandage changes. Her donor site from that last procedure is almost completely healed. Obviously, cosmetically doesn't look as nice. And then here you can see her leg is healed. She has great ambulation. Everything looks good there. And she just has this smaller area that is still healing and kind of slowed or stalled a little bit at this point. In her perianal region, the best part is that flap. It's nice and haired and looks really good. As far as morbidity with this case goes, the things that we were definitely struggling with was that she had a urinary and fecal catheter for quite a long time. She certainly was kind of self-mutilating at one point when the collar was off, and she did have to have a digit amputation related to that, which I left out for time, but that probably could have been prevented. At the end of the day, we tried to keep this bill as minimum as possible, but their bill ended up being over $70,000 for all of this, and probably could have been a lot more, especially without donation of those products. This is what we're left with about a year later that's healing on its own. I would love to reapply cod skin and graft this and be done with it pretty quickly, but the owners don't really want to spend more money or do a procedure at this time. So she's happy, healthy, doing great, but that is kind of where we're at based on owner exhaustion financially and emotionally. At one point, we did have a culture that she grew resistant bugs, not surprisingly, from the hospital. And we were able to treat primarily with topical therapy to get her through that without much additional concern. These are some of my kind of comments or questions I would have loved to ask the audience and see what different people were thinking as far as applying the VAC earlier, whether that would have been possible, and then any ideas for different approaches that people would have used. And I'd love to stick around this afternoon and talk about that if anyone's interested. This is Layla's goodbye party from the hospital, where we all wore bodysuits to say goodbye to her. And then, of course, I want to shout out thank you to Dr. Stanley for her brain on this case at the beginning, especially the Soft Tissue Society for letting me speak, and then the donations that we received from those companies for her, and then certainly thanking my co-authors and Layla's family. At this time, I'll take any questions that you might have.
I'm going to be talking about Puff. He was a 2.5-year-old male castrated ragdoll with no previous medical concerns, at least according to the owner the first time we chatted with him, and he wasn't on any current medication when he presented to us. His initial presentation was through the emergency service for acute onset pelvic limb paraplegia after a fight under a bed with a housemate. Upon further probing, however, the owner did mention that Puff had experienced an acute onset of paraplegia a year before, in which all he did was change Puff's diet and he got better on his own. On presentation, his physical exam findings were hypersalivation, tachypnea, pelvic limb paraplegia with limbs being cold to the touch and a purple hue to them. They also had absent withdrawals to pelvic limbs, but his cranial nerves and the rest of his neurologic exam was intact. Initial blood work diagnostics were run, and you can see the results of a NOVA drawn from the front limb versus the hind limbs, and the findings are quite consistent with arterial thromboembolus disease in kitties or FATE. Because of this, imaging was recommended and performed. Thoracic radiographs revealed a diffuse unstructured interstitial pattern, but it was quite mild, not consistent with congestive heart failure. An abdominal ultrasound was performed, which showed multiple ill-defined echogenic clots or material within the lumen in not only the mid-abdominal, but the cranial abdominal and caudal abdominal aorta. Plus, there were no Doppler signals in the external or internal iliac arteries. And this is another view of the ultrasound findings where you can see the void there within the abdominal aorta. An echocardiogram and hospitalization was recommended and declined by the owner at this time due to finances. The outpatient treatments that were performed for Puff included hypertonic saline bolus, methadone, was given IV twice, fluid boluses. The owner was counseled on the grave prognosis with feline aortic thromboembolism, even with aggressive treatment, but he adamantly declined euthanasia at that time. And so patient was sent home on clopidogrel, enoxaparin, and a 25 microgram fentanyl patch. 6 days later, Puff represented vocalizing in pain with continued paraplegia. Since returning home, Puff was unable to walk, but the owner felt the color had improved. I think that could be uh, argued with from this picture. Owner reports that Puff was now able to swing his tail, which he couldn't do before. The owner had been administering the medication prescribed as well as giving vitamin C and B and aspirin. On physical exam this time, Puff was semi-comatose, tachycardic, hypotensive, and hypothermic. His pelvic limbs were both cool to the touch, stiff with purple discolorization and pitting edema, and there were no pulses palpable. He was very systemically ill at this time. He was azotemic, acidemic, hypocoagulable in a tag, hypoglycemic, hypokalemic, and hypocalcemic. The hypocoagulable state was probably due to the anticoagulant therapy that he was on at the time. He was hospitalized this time under the critical care service and given, again, a very guarded prognosis, and euthanasia was recommended, but again, declined by the owner. In hospital treatments at that point included IV catheter placement, methadone administration, dextrose and calcium gluconate, IV administration, fluids with dextrose. We discontinued the enoxaparin and aspirin and continued the clopidogrel, ampicillin, famotidine, Cerenia, and recumbency care were initiated. Day 2 of hospitalization, an echocardiogram was performed, which revealed a normal heart structure and function. So the left and right ventricle structure were structurally normal and functionally normal with no atrial enlargement. The left ventricular outflow tract flow was laminar with normal velocity. There was no valvular regurgitation. No pericardial or pleural effusion was found. At this time, we could not find a specific cause for thromboembolic disease on our diagnostics, our echo or abdominal ultrasound. Further diagnostics, which we felt would help us characterize this, were declined by the owner due to cost. Those diagnostics would have been abdominal CT with angiography, looking for a vascular anomaly or further coagulation testing, looking for platelet or coagulation factor abnormalities, plasminogen defects, but the owner declined that due to cost. Hospitalization over the course of 4 days, the pelvic limbs continued to show signs of ischemia reperfusion injury. Puff's kidney function improved and his hypoglycemia and hypocalcemia resolved. He was initially more comfortable on eating, but then became non-responsive and anorexic on day 4 of hospitalization. His limbs became gangrenous and mummified, as you can see in this picture. On day 4, surgery was discussed with the owner. At this point, a clear demarcation line was seen along the pelvic limbs, and Puff was decompensating. The hospital staff was quite connected to Puff and quite attached. Surgery was strongly recommended, bilateral amputations, or euthanasia. The owner refused euthanasia for any reason. He had severe financial concerns, so we heavily discounted the bilateral amputation surgery due to patient care. He was very resistant to a full disarticulation, which was the recommended surgery, due to recommendations from physical therapy that mid-femoral amputation may be better for use of a cart post-op, and he was convinced, the owner was convinced that a cart was going to be necessary for Puff. He was aware that the skin and muscle may continue to necrose and a second surgery might need to be done, but he wanted to try the mid-femoral, and he agreed to an esophagostomy too. These are pictures of Puff the day of surgery, just showing that clear line of demarcation. It had not moved over the preceding 4 days. These are pictures of Puff post-surgery. It doesn't look like there was a mid-femoral, but there was a mid-femoral um, procedure performed. 3 days post bilateral mid-femoral amputation, Puff was discharged. He appeared comfortable. There was no discoloration of the tissue at the incision. Azotemia resolved, and he was taking his E2 feedings well. His culture from surgery came back with Pasteurella, and he had been sent home on buprenorphine, clindamycin, which was a good antibiotic for his culture, Cerenia, enoxaparin, and Mirena capsule. Unfortunately, over the course of the next few months, Puff encountered many complications of healing. Picture on the left is day 6 post-op that the owner sent me, showing clear continued necrosis of the skin. This is day 12 post-op when we were able to get Puff back into the hospital for debridement. Day 22 post-op, Puff came back in with clear visible femoral stump showing through his incisions bilaterally, which required multiple staged debridements of not only the bone but the tissue, and bandage placement, which the owner was very dedicated to maintaining at home. Unfortunately, the dehiscence of the skin incisions continued, and 6 weeks post-op, the initial mid-femoral amputation, the owner finally agreed to a bilateral disarticulation amputation. Puff was hospitalized just one night and discharged the next day. 2 weeks post that procedure, his skin had completely healed, and he was doing well. Patient check-in at that point. He was eating and drinking well at home. He was not currently on any medication, no vomiting, diarrhea, or coughing. And the owner was trying to train Puff to walk in a cart. Puff seemed a little reluctant to the cart training, but was trying like a little champ there. 1 month later, he presented for a mid-tail wound and distal tail necrosis, again, an unknown cause. A tail amputation was performed as an outpatient procedure, and he was sent home on clopidogrel with strong recommendations to follow up with the internal medicine department for a long-term plan. 6 months after initial presentation, he presented to general practice for an annual exam, and at that time he was doing well at home, moving around the house on his own, and on no medications, regardless of our recommendations. He has not followed up with internal medicine. Owner reports he did not use the cart and was just walking around the house on his own. This is a picture of Puff coming out of the litter box, which was a big concern for everybody at the hospital as to how that was going to happen. How was he going to be able to manage the litter box? And walking around without the use of a cart. He gets around quite well. Pretty amazing. So this is an uncharacterized thrombotic case, but not because it couldn't be characterized, but basically because we had some problems with being able to characterize it. Money got in the way of this, as well as owner wishes. So why is Puff creating these clots? I think I'm concerned that he's had now 3 separate thrombotic events, one a year before he first presented to us, then his first initial presentation to us, and then 2 months afterwards with his tail also having some sort of unknown reason for necrosis. So why is he creating these clots? Heart disease is obviously the most common cause in cats, but it's not the only cause. There can be primary vascular disease. There can be primary hypercoagulability disorders. Trauma can lead to it. And as well, metabolic neoplastic inflammatory diseases can also lead to clot formation. What would have been the ideal diagnostic plan for PUFF? Well, we would have liked to have done an abdominal CT with angiography to look for any type of aneurysm, AVM, aortic coarctation, coagulation testing, TEGs, plasminogen defect tests, specific factor deficiencies we could have looked into, possibly even a vascular biopsy, and then a full spectrum of metabolic testing. But as I said, money was the key factor with why we weren't able to do those. Therapy for PUFF long term, platelet inhibition, heparin therapy, and direct factor inhibition could all be considered. Obviously, if we found a vascular abnormality, surgical or IR interventions would be ideal. I wanted to present this case because I've seen three cases of double limb amputations over the last few years. Two of them were pelvic cases. One is PUFF from thromboembolic disease, and one was a chihuahua with neurologic disease that was self-mutilating. There was also one thoracic limb case with bilateral severe trauma. All of the patients have adapted very well to these double limb amputations. Two of the three were young animals, and two of the three were dogs, but they all resumed ambulation, regardless of their age and their breed or species. So, in conclusion, I feel like this case was very difficult for our hospital on many levels. We were stymied at being able to figure out exactly why this was happening to PUFF, which made treating it very difficult. There were ethical questions with our staff. They found it very troubling to be nursing PUFF during those 4 days he was hospitalized before surgery. And then after surgery, when he was having all those complications, it was quite difficult for the staff. So there were ethical questions about continued care and whether PUFF was suffering with an owner who refused to even consider euthanasia. The uncharacterized disease was very difficult for us because we feel like he has a high risk for clot formation. So he may be needing lifelong anticoagulation, but he also has been not an owner that has followed recommendations for follow up. So we have a high fear that this may happen again to PUFF. Another thing to bring up, though, was that regardless of his disease and his long surgical uh, care that was required, he did eventually have a very good outcome. And I've seen other good outcomes with these double limb amputations. So there is a possibility for a good outcome with these cases if you have a dedicated owner. And then lastly, just the question on whether or not mid-femoral amputations are a good idea. Are they more helpful for a cart in order to fit into the cart, more stable? Or should we just be doing these disarticulation amputations? There are things like drag bags that dogs and cats have used, which allow them to slide along the floor a little bit smoother. As you saw with Puff, he bulked up his front limbs and just carried himself, so he didn't even need a drag bag. My experience with Puff makes me less inclined to do another um, mid-femoral amputation in the future. Thank you so much again for listening to this case report and to the Soft Tissue Society, and I would be happy to take any questions at this time.
So the idea for this study began on a date night that I went on with my husband. My mom was watching our kids at home, and we had turned our phones off because we went to a comedy show, and they asked us to turn our phones off. So we complied. And as we were leaving, I checked my phone and had a frantic message from my mom saying that she was at the children's hospital with my son Raymond. And here he is. We immediately drove to the children's hospital to see what was going on, and lo and behold, he had sustained a scalp laceration fighting with his brother over a bouncy horse. and he had hit his table on a wooden, he had hit his head on a wooden table. So this is how I learned about the hair appositional technique that was first described in 2002 out of Singapore. And they looked and compared the hair appositional technique to standard suturing. So the hair appositional technique, basically they take 4 to 5 strands of hair in bundles on either side of the scalp laceration, and using forceps, they cross those strands over. They make a single twist to help oppose the wound, and then they secure the hair itself with a drop of glue. And they compared that to suturing. So their inclusion criteria were lacerations that were 10 centimeters in length or less, that were not extremely contaminated, so that could be, lavaged out with just topical lavage, and that did not have uncontrolled bleeding coming from the scalp. So there was no arterial bleeding that needed to be addressed in any way. They talk a little bit in the study about how one technique that had previously been reported was basically tying the hair together if the hair was long enough, but that hair is so smooth that a lot of times the knots that they would tie would become undone. So this was kind of expanding on that a little bit, using the hair to pull the skin edges together, but instead of tying it, using glue. And what they found was that most patients did very well with the hair appositional technique. There was less scarring than in the suturing group. There was less wound breakdown, and there was just a much lower rate of complications. When they looked at patient satisfaction as well, at over 80% of those in the hair appositional technique group would have it done again, compared to I think 35 or so percent in the suturing group that would have it done again. The hair appositional technique group also had much shorter procedure times, and had much lower pain scores when the patients were asked to score their pain both before and after the procedure. The same group looked at the cost effectiveness of the hair appositional technique compared to standard suturing, and found that there was indeed cost savings when the hair appositional technique was performed compared to standard suturing. The same group in Singapore also looked at comparing whether nurses could do this technique as well as physicians. And so in this study, they basically had 2 groups. One was opposed by physicians, and the other one was done by nurses. And they found that there were basically no differences in outcomes between the doctors and the nurses. The only thing that they found was that nurses took a few minutes more to complete the procedure. So it took 12 minutes instead of 9 minutes to complete the procedure. This is a study, it's came out of Turkey, and basically it is a modification on the hat technique. And this is the basic modification, is that they looked at shorter hair. They were able to do this technique down to hair lengths of only 1 centimeter, and they found that it worked pretty well, even with hair that was that short. That group also looked at, did a retrospective looking at the hair appositional technique, suturing, and stapling. And basically they found that people tended to be more satisfied with the hair appositional technique, and the complication rates were much lower in the 2-week time frame with the hair appositional technique, comparing that to suturing and stapling. So I thought about this and I was like, I don't know why we don't do this in our own patients, because they're covered in fur or hair and get lacerations all the time. And I started talking to some interns that we had, and some of them were interested. And of course, at a busy moment in my life, my own dog decided to get a tail laceration in some unknown way under my dining room table. I assume children were involved somehow, but I decided to glue his tail together and see what happened. And so on the left, you can see his initial wound. Basically, I cleaned it up, and then I twisted his fur together and applied glue. And in the picture on the right, that is, I think about 2.5 weeks later, I did clip the fur off of his tail so that I could assess it. And you could see there's a little scab, but otherwise it had healed up pretty well. Note to self, don't use Gorilla Glue. That was all that I had, and it made a giant mess of his fur. So I don't recommend Gorilla Glue, but it did work for me and my own dog. So for what that's worth. So in our study population, we've only actually accrued 5 cases so far. 3 have been in, and I'm doing a prospective randomized control study, and I've got 5 cases so far. 3 in the hair appositional technique, 2 in the standard suturing. The first hat one that we did not heal very well, and it needed to be resutured. It was on the pinna of a Rottweiler, and the other 2 cases were standard suturing techniques. So why am I here? I want to know if anybody else is interested in doing this study with me. It's been challenging to accrue cases, mainly because of the way our teaching hospital model works at the University of Calgary. I had no interns that were interested in participating and helping to accrue cases this past year. And because we have a distributed teaching model, even though I tell people to call me if they have adequate cases, they're busy referral practices and they don't think about it, they don't call me. So I need somebody in the hospital who's vested, and right now I don't have that. So I think it's kind of a neat idea. I'm hoping that somebody else, or maybe a few other people here, would be interested in participating as well and getting cases. I also think I need a better name for this project, like the hair appositional technique in animals or the fur appositional technique. So there's my email address, and I'm happy to take questions.
And I will give extra credit to anyone who can tell me the name of that little mouse down at the left-hand corner. So pertinent history with this patient's name was Stephen. 5 months prior to our presentation, he was attacked by his housemate and bitten on the left ear. At that time, the wounds were superficial and Stephen was stable. No surgical interventions were necessary, and the patient was not even sent home on any medications. But lo and behold, 5 months later, this 3.5-year-old male neutered French bulldog was at a dog park when he was attacked by a pit bull. He was then brought into the emergency service for evaluation of a severe bite wound to the left pinna. The owners had indeed saved the ear tissue and brought it into the hospital for us to reattach it. Sadly, we were not able to do that, but on initial exam, this is what the wound looked like. He was tachycardic, hyperthermic, tachypnic. He had a moderately normal to high blood pressure. And as you can see there, he had a degloving injury to the dorsal haired surface of the left pinna with also some of the cartilage on the lateral and ventral surface also missing. He had no other physical exam abnormalities. His NOVA was unremarkable. PCVTP was normal. Otherwise, very healthy dog. So at that point, there was a discussion with the owner from our ER service, and surgical options were discussed. A partial penectomy was recommended, but declined outright by the owner. We tried very gently to explain to the owner that a pinna was not physiologically necessary and that Stephen would live a very happy and healthy life, but the owner had looked up penectomy pictures on the internet and was absolutely against it. He felt that he did not like the look of it and he wanted to explore any other option. And so an axial pattern flap was discussed with the owner, but the owner was severely warned of complications, including necrosis of the flap, infection, need for second surgery if there was necrosis, leech therapy being required potentially, and obviously most important to me was that the ear itself would look different than the contralateral ear. And so if the owner was expecting perfect cosmesis, this was not going to happen. And so I was very, very clear with him before surgery. So surgical procedure that was picked was a caudal auricular flap. Due to the location and the robustness of the flap, I felt that it had a high chance for vascular success at least. And you can see us raising the flap in the top picture, and that is what the flap looked like at the bottom. And I was actually pretty happy with how the skin reattached to the cartilage. We had to do just minimal debridement of the cartilage. He was hospitalized on IV fluids at maintenance rate, fentanyl, meloxicam, Cerenian, Vaseline, and we set the owner up for the potential for leech therapy the next day if needed. This is a picture of Stephen the next day. The tissue is pink, but you can see there's a moderate amount of swelling and thickening to the flap. We ultrasounded the flap, and there was a small pocket of fluid, but I could only aspirate 1.5 cc's of serosanguinous fluid from that little pocket. He seemed very comfortable, but he did have a head tilt to the left, and we felt like it was probably just due to the weight of this new ear and him getting used to it. He was discharged 2 days later. There was no visible congestion, so we did not use leeches. He didn't have any incisional dehiscence, and the skin palpated normally, but it was still very thickened. He was discharged with an e-collar, tramadol, meloxicam, and Simplicept since we were still pending his culture. He came back a week later for a recheck, and he, at that point, was having some moderate serosanguinous discharge from the incision at the lateral base of the new pinna. He was eating and drinking, otherwise very happy. He had a seroma on ultrasound present along the dorsal aspect of the pinna with this clear serosanguinous discharge. There were no sutures missing or disturbed, and his cervical donor site incision was clean, dry, and intact. The incision was cleaned very gently with chlorhexidine and saline, and the seroma was expressed through the little hole on the lateral surface. Ultrasound of the tissue revealed really more of a cellulitis versus a remaining pocket. And we sent him home with recommendations to hot pack the ear if possible and continued gentle cleaning of the discharge and recheck in a week. This is a picture just kind of showing that area where the discharge was coming, right at that lateral ventral base of that pinna. And I would point out that you can see that the tip of the ear is already sort of starting to curl back caudally, which is something that we see a lot with our oral hematomas as well, when the cartilage doesn't reattach to the skin totally normally. At 12 days post-op, Stephen came back in. He was once again doing really well, except he had a persistent head tilt. The discharge from the incision had lessened dramatically, but he did still have moderate thickening and cellulitis to the tissue. There was no pain on palpation of the pinna. The cervical incision was healed fully, so that sutures were removed from that part. He did have bilateral otitis at this point, yeast and cocci, so he was sent home with ear cleaning and ear medication. The pinna incision sutures were all absorbable, so those were left. And we discussed with the owner that this thickening to the ear may be permanent. I was not sure if it was going to go away. He had been on anti-inflammatories, he had been getting hot packed, the cellulitis seemed very persistent, and it was not drainable. So the head tilt too may be permanent if he was consistently uncomfortable with the weight of this new ear. And I reminded the owner that we did not know what the outcome of this flap was going to be, and that if it continued to cause a problem or seem uncomfortable to him in any way, we may have to consider a revision surgery or penectomy. A week later from that, 3 weeks post-op, patient presented for another recheck. Again, he reports that Stephen seemed very comfortable, eating, drinking, very happy, but he still had this head tilt. The ear cytology seemed improved from last time. The pinna incision was fully healed with mild scabbing, appropriate texture and color, but there was still this moderate thickening. He was not painful. We discussed having them come back in through our GP service for a thorough ear canal exam under sedation. And I again reminded the owner that if we felt that his quality of life was not good with this pinna causing a head tilt, penectomy would be required. Owner was adamant that he was happy with the cosmesis of the ear, and he did not want a penectomy. 28 days post-op, so about a month later, he came back in, and these are the pictures. Owner is bottom right corner. You can see very happy. They had been being very diligent with the ear medications, and at that time he did not have an ear infection. The incision was completely healed. There was still thickening, but it was localized to only the pinna now, the dorsal surface. There was no discharge. Once again, appropriate color and texture and palpation. He felt that the head tilt was almost completely resolved at this point as Stephen was getting used to his new ear. 5 months post-op, Stephen made a recheck visit with me just to kind of show off his new ear. As you can see in the middle picture, that tip of the articular cartilage is flipped backwards, and there's still some thickening to the skin around the caudal surface of the pinna, but it's sitting up a little bit more upright than it was previously, and Stephen was very, very happy. A year and a half post-op, I just got these pictures from Dad just a week ago, and you can see the swelling has gone down dramatically. And really, other than the tip, he's able to hold up his ear very, very normally. So Dad is super happy with this, and it goes to show you what a dedicated owner will get for his dog. In looking at this case, I did a little bit of research on auricular trauma in dogs, and really there are no articles relating to pinna reconstruction in dogs that I could find on PubMed. There are multiple descriptions, of course, about oral hematomas, and there are these 2 articles on treatment of auricular defects. They're talking more about the ear canal rather than the pinna, and then techniques to try to avoid total ear canal ablation in those cases. Axial pattern flaps, however, there are multiple journal articles on, and this is a more recent one, just kind of looking at them in general and looking at their complications and their success rates. Chronic wounds was one of the most common reasons for axial pattern flaps, and then followed by tumor resection. So not as common to be used for an acute trauma, but obviously it's done for that. Post-op complications were seen in 89% of patients, and those complications did include swelling of the flap, which we saw here, infection, discharge, and seroma, which we also saw in this case. However, flap outcome was excellent in 23%, good in 41%, and fair in 30%. So even though there's a high complication rate, the flaps do tend to heal, and the complications do tend to be easily managed, which we saw in Stephen's case as well, if you have a dedicated owner. Auricular trauma in people is much more common, although it's not the most common, but it's more common than I think we see in our veterinary patients. And they do some pretty amazing things. So this is a picture of a pocket technique where they actually debride that piece of cartilage that was brought in by the owner and put it back onto the ear, and then they put that whole thing into a pocket, a caudal auricular pocket. And that's considered the pocket principle with that post-auricular flap. Other techniques they use are composite grafts, where you just immediately reattach. Then there are microvascular reimplantations. Those tend to be a two-stage technique. Picture up at the top is a radial forearm technique. And then they also, talk a lot with those microvascular reimplantations about the need for leeches, infection, blood transfusion. So can be very complicated. Then there are also split thickness grafts, and that mouse at the beginning of the talk was called the Vacanti mouse, named after the inventor of that mouse. That was a technique where they were trying to grow cartilage in a specific shape in order to potentially transplant onto children. With total amputations, auricular amputations in people, they have about a 69% success rate with the microvascular technique and only a 25% success rate with the pocket technique. But with partial amputations, they have a better rate with the pocket principle than with microvascular. And those are just those small little amputations like in the picture that I saw. So in discussion, is the use of a flap possible for auricular damage? Yes. Do you need a dedicated owner? Yes, absolutely. If Stephen's owner was not as dedicated sadly to cosmesis, we would have definitely stopped before it had fully healed. Other techniques possible for dogs, like the pocket technique or microvascular reimplantation, free grafts or split thickness grafts, I think yes, those things could be looked at. But the real question is, why do we want to look at those? Because most of the time, it is really for cosmesis. So do we need to be doing this? These ears are not going to look perfect. I was very pleased a year and a half later with how well it looked, but it still wasn't perfect. And does that matter to our patient population when it requires a long recovery, a higher cost, and potentially some discomfort to the pet? So those are some things for us to consider. Thank you so much to the Soft Tissue Society for letting me speak about this case, and I'd be glad to take any questions at this time.